Hi, everyone. Welcome to the National Surgical Teaching Society's spring series, which is we're covering MRCS revision. This will be a whistle-stop tour of some of the core topics that are faced in the Part A exam. And I know many of you will be preparing for the May exam. And so what we wanted to do today was, covering in the rest of the sessions as part of this series, is to essentially go through some high yield questions as examples. These are questions that we've compiled from people who have recently sat the exam, so should be relevant to the exam as well as commonly faced topics within the exam itself. And now, you know, this series isn't designed to teach and give you theoretical knowledge, and hopefully you guys are spending the time to cover those areas yourselves. It's just drilling SBA questions, MCQ questions, and so hopefully consolidating topics that you're covering, facing, and hopefully as well throughout, you know, getting some tips along the way to hopefully with a view of having everyone passing the exam. So my name's Byung Choi. I'm one of the core trainees in KSS, having recently passed my exams. Fortunately, the speaker we had aligned today couldn't make it, so I'll be stepping in. So this session is going to be on applied anatomy, and with time in mind, we'll crack on. So I think how we'll do it is as so. We'll come on to a question. I'll read out the question and I'll give you about 30 seconds to a minute to think about it, maybe with a piece of paper or Word document or whatever you have in front of you. Jot down the answer of what you think it is, and then we'll reveal the answer and talk about the rationale behind it. So a 29-year-old male was struck on the side of the head with a hockey stick playing sports. On arrival to A&E, he was unconscious, had bruising over his right pterion. Now, which of the following bones do not make up the pterion? So those are the options there. A, frontal bone, B, parietal bone, C, sphenoid, D, temporal bone, E, zygomatic bone. So I'll give you a minute or so to think about that and jot down your answers. Now, I can't personally myself see the participants who have tuned in, and I'm not sure if they can call out, but does anyone want to jot down in the comments section what they think the answer may be? Okay, so moving on, the answer to this question would be E, the zygomatic bone. Okay, and as we see from here, from the lateral view of the skull, the pterion, which is a key anatomical landmark, which comes up quite a lot in exams, either as an anatomy question or as part of the neurosurgical questions. It's made up of the frontal bone, the parietal bone, the temporal bone, and then the sphenoid here in pink. Now, the zygomatic bone, which was not part of the pterion, would be the answer here, and that's slightly more anterior in relation to the pterion. And clearly, I'm sure you are all aware that the pterion is the anatomical landmark for the middle meningeal artery, which runs closely behind it, and any trauma to this area, which is a susceptible weak point, may lead to hemorrhage, that then may lead to an extradural hematoma. And any questions you have along the way, just put them in the post. And also towards the end of the session, at the end, I'm happy to stay for another half hour or so for any questions that you don't get to ask, okay? And this type of question, and you'll see from following this, many of the questions of how they structure it in Part A is that it will be asking about what isn't part of the question. So for example here, which of the following bones do not make up the pterion? And so you have to think about, you know, the foundation of the anatomy and what is the odd one out, essentially. So moving on, which of the following structures does not pass through the superior orbital fissure? A, trochlear nerve, B, ophthalmic vein, C, frontal nerve, D, lacrimal nerve, and E, ophthalmic artery. So again, I'll give you about 30 seconds to a minute to think about this one. Okay, so the answer to this question would be E, the ophthalmic artery. Okay, so cranial foramina comes up every year, really common, probably multiple times per exam. So it's worth something, it's something that you should drill in your heads and learn inside out. And obviously this is quite a convoluted image to actually go through, but for this specific question, the superior orbital fissure, it contains the oculomotor nerve, the trochlear nerve, the ophthalmic nerve, which is the V1 division of the trigeminal nerve, the abducens nerve, and the superior ophthalmic vein. And something to, you know, think about is these are the structures that pass through essentially the sphenoid dural sinuses, and the ophthalmic artery is carried through in the optic canal along with the optic nerve. Okay, so that's the odd one out in this question. Okay, so we'll move on to the next question. Which of the following structures does not pass through foramen ovale? A, mandibular division of the trigeminal nerve, B, accessory meningeal artery, C, emissary veins, D, greater petrosal nerve, and E, lesser petrosal nerve. So again, about 30 seconds for this one. Okay, so the answer to this question would be D, the greater petrosal nerve. Now, I always found these type of questions really tricky because clearly, you know, with all the cranial foramina and all the small structures that go past through it, it might be quite difficult to remember some of the lesser structures that we meet along the way in terms of going through med school and then in our revision. But for foramen ovale, something that I use to try to remember is the mnemonic ovale itself. So O for otic ganglion, which doesn't actually pass through foramen ovale, but it sits under it. V for V3, which would be the mandibular division of the trigeminal nerve. A for accessory meningeal artery, so that passes through it, so it can't be B. L is for lesser petrosal nerve, and E is for emissary veins. So here, G isn't part of ovale, and so the answer to this question would be D, greater petrosal nerve. Okay, so again, this is just a diagram of the foramina contents, and it's something that is definitely worth learning inside out, as it will definitely come up in some form of capacity. And often it is a question of what passes through it or what doesn't, what's the structure, odd one out, and that's how they will structure it. So moving on to this question. A 30-year-old has been experiencing painful swelling in the floor of his mouth that becomes more painful during meals. A bimanual examination of the patient's mouth suggests a stone in Wharton's duct. What is the best anatomical description of the opening of Wharton's duct? A, floor of the mouth. B, buccal mucosa opposite the lower second molar. C, buccal mucosa opposite the upper second molar. D, either side of the frenulum of the tongue. Or E, none of the above. Okay, so the answer to this one would be D, either side of the frenulum of the tongue. Now, I always found these type of questions a little bit tricky because for some reason I always got Wharton's duct and Stenson's duct mixed up sometimes. Now, Wharton's duct is from the submandibular gland, whereas Stenson's duct would be from the parotid gland. And that opens up opposite the upper second molar, which is C. So the submandibular gland opens up either side of the frenulum, and it's the duct that comes up from the submandibular gland, running along the floor of the mouth until it opens up at the frenulum. And so this diagram shows nicely where that would come out. And so you've got the sublingual gland that gives off multiple sublingual ducts across the mouth, the floor of the mouth, whereas the submandibular gland gives off Wharton's duct that comes out either side of the frenulum. And Stenson's duct is up here, given off by the parotid gland going across and the upper second molar into the mouth there. And for some reason, they really like putting a lot of head and neck questions in this exam. And it's similar to, in Part A and Part B, they just really like to drill these type of questions. So it's worth noting down the course of the ducts as well as the openings, because they often come up in different ways. So following on from that, the next question. The 70-year-old man presents with weakness along the right side of his mouth and lower lip. He recently underwent excision of submandibular swelling. He has difficulty closing his mouth and moving his lower lip. What nerve is most likely to have been affected to cause these symptoms? A, mandibular branch of the trigeminal nerve. B, glossopharyngeal nerve. C, the lingual nerve. D, hypoglossal nerve. And E, marginal mandibular branch of the facial nerve. Okay, so essentially for this question, even if you don't know the exact anatomical outline of the submandibular gland and what structures may be at risk, you should be able to just work it out from the patient's symptoms. And so the key part is that he has difficulty closing his mouth. So that suggests some form of asymmetry and a motor effect. And he's having difficulty moving his lower lip. Now, if you go through, your answer would have been E, the marginal mandibular branch of the facial nerve. And clearly the facial nerve, the superficial branches that come out after and over the parotid gland, they supply the muscles of facial expression, something we test for in the cranial nerve exam. And so E comes out, the marginal mandibular branch comes out and affects essentially the mouth. And that's a common thing you would be consenting patients for in a excision of a submandibular gland. And, you can go through by way of exclusion. A mandibular branch of the trigeminal nerve we know is largely sensory to the lower third of the face, as well as its motor part that supplies the temporalis muscle and the masseter muscle. So it wouldn't essentially do fine movements of the mouth or the lips. Glossopharyngeal nerve, again, it doesn't affect motor to the mouth. It's more motor sensory at the back of the throat, affecting the pharynx and the oropharynx. C, the lingual nerve, again, we know that is somatosensory to the tongue. D, hypoglossal nerve, is motor to the tongue, not the lips. And so it leaves you with E, and hence that's the answer for this question. So moving on to this one. A patient is due to undergo a carotid endarterectomy procedure. Which of the following structures lies parallel and immediately deep to the carotid sheath in the neck? So A, vagus nerve, B, recurrent laryngeal nerve, C, the scalene anterior muscle, D, trachea, or E, sympathetic trunk. So I'll give you another about 30 to 40 seconds on this one. Okay, so the answer to this one would be E, the sympathetic trunk. It's quite a tricky one, and you'll find that in a lot of Part A exam questions, you'll get asked what structures lie in relation to X. And so knowing the relations of key structures will be useful. And unfortunately, one of the best ways of doing that is just drilling questions about on these topics. But the carotid sheath in the neck anatomy seems to be quite a common one that they pick out as one to test for. Now, if you go through these options, clearly we know that the trachea wouldn't really lie immediately deep to the carotid sheath, as that's in the midline. The vagus nerve lies within the carotid sheath. So you're left essentially with B, C, and E. Now, again, with B, the recurrent laryngeal nerve, you know that that's a branch of the vagus itself, and it branches off quite deep, more within the thorax itself rather than within the neck. And that's where the procedure is happening. So it's unlikely to be B. And if I show you this, this slide here, it's a schematic of the carotid sheath. And something that I always just muddled up inside my own head was the relation of where the sympathetic trunk lay and where the ansa cervicalis lay. And how I remembered it was that ansa cervicalis begins with A, is always anterior to the carotid sheath, whereas the sympathetic trunk lies directly posterior to the carotid sheath. Hence, that is the answer to this question. And the other option, which left us with a scalene anterior, the carotid sheath lies deep from that scalene anterior and actually runs more towards the posterior triangle in the, more deep inferiorly to the scalene anterior muscle in the neck. And so it can't be that. So the answer here is the sympathetic trunk. And if you learn that rule of ansa cervicalis being anterior and sympathetic being posterior to the carotid sheath, you would find that the buzzword of where, if they ask what is immediately deep or posterior or anterior, you would know it's either the cervicalis, ansa cervicalis, or sympathetic trunk. So moving on to this question. A 29-year-old female undergoes a right superficial parotidectomy. 8 months later, he presents to the outpatient department complaining of flushing and sweating on the right side of his face whilst eating. Pathological re-innervation of which nerve is responsible for this condition? So you have A, greater auricular nerve, B, facial nerve, C, trigeminal nerve, D, auricular temporal nerve, and E, greater petrosal nerve. So I'll give you about 40 seconds for this one. Okay, so the answer to this question would be D, the auricular temporal nerve. And essentially the condition that they are getting at here is called Frey syndrome, which is a complication from parotid surgery or parotid excision surgery, where damage to the auricular temporal nerve, as it recovers, it can get reinnervated with sympathetic fibers contributing to it that causes flushing and sweating, essentially, especially when you eat, when the parotid gland is activated. And it is, so the auricular temporal nerve, it's a branch of the trigeminal nerve, and it carries fibers to the parasympathetic fibers to the parotid gland. So when we eat, the parasympathetic gland will be activated, hence producing gustatory secretions into the mouth from the parotid gland. Now, if you look at the others, although facial nerve can be a complication from parotid surgery, it's less likely to cause Frey syndrome, because damage to the facial nerve cause within that surgery, you essentially get more Bell's palsy, and rather than Frey syndrome. Greater auricular nerve is just a sensory branch. Now, the trigeminal nerve is obviously a massive nerve with its branches that I'm sure you, as we're all aware, and that is not in the area of the parotid gland to be damaged, and also it wouldn't cause Frey syndrome. And again, greater petrosal nerve, although it carries parasympathetic fibers, it's not the branch that innervates the parotid gland. So auricular temporal nerve is the answer to that question. So moving on, going more into the abdomen now, which of the following does not form a boundary of Callow's triangle? So A, inferior border of the liver, B, common hepatic duct, C, cystic artery, D, cystic duct, E, aberrant right hepatic artery. So I'll give you a few seconds for this one. Okay, so a bit more simple on the spectrum of MR Part A questions, but the answer is C, the cystic artery. And I'm sure you're all aware that Callow's in dissection of the gallbladder in a lap coli, you identify it to visualize and identify the cystic artery essentially. And so by definition, it wouldn't form a boundary. And I'm sure you can see from this image and visualizes that nicely. So within Callow's triangle, you've got the cystic artery and lymph nodes mainly. You may get an aberrant artery, but yeah, the main classic textbook borders would be the liver edge, the inferior hepatic border, as well as the cystic duct, and then the common hepatic duct. So moving on, a jaundiced, unkempt 45-year-old man presents with sudden onset massive hematemesis. The gastroscopy, or OGD, reveals bleeding esophageal varices. Which one of the following is true about the anatomy of the portal venous system? So A, the portal vein arises from the confluence of the splenic and inferior mesenteric veins. B, the portal vein arises behind the neck of the pancreas. C, the portal vein drains the GI tract from the upper esophagus to the anorectal junction. D, the portal vein lies anterior to the common bile duct and hepatic artery in the lesser omentum. E, the superior mesenteric vein drains the sigmoid and transverse colon. So I'll give you a bit more for this one. Okay, so this question is a bit more wordy, especially the options that they give you. And that's one of the things that surprised me when I did my Part A. Some of the stems or the actual options within the MCQ were really word heavy. And so that was part of what contributed to the time pressures that you may face. And so that's something to bear in mind when you're practicing the questions. But for this question, the answer would be B, in that the portal vein arises behind the neck of the pancreas. And so again, for these type of questions, I always just try to deduce, going through each one and trying to see whether they were true or not, essentially. And so going through them, A, the portal vein arises from the confluence of the splenic and inferior mesenteric veins. And we know that splenic, it's the splenic and superior mesenteric veins that form the portal vein, and the inferior mesenteric vein is a contributor of the splenic vein. C, the portal vein obviously doesn't drain the GI tract from the upper esophagus to the anorectal junction. The anorectal junction has contributors from the systemic system into the common iliac vessels, as well as the the esophagus itself has different blood supply across the upper third, middle, and lower third. And it's the lower third of the esophagus that may contribute to the portal system, but it's not the portal vein itself. And then D, the portal vein lies posterior rather than anterior to the common bile duct and the hepatic artery. And that's something, I think there's a question later on about that, this is a question again. They love asking about the lesser omentum or the lesser sac or the epiploic foramen and the structures that lie within that. And they'll ask a lot about the relation between the three structures there, the common bile duct, hepatic artery, and the portal vein. And then finally, E, the superior mesenteric vein doesn't drain the sigmoid and transverse colon because it would be the inferior mesenteric vein that drains. Sigmoid definitely. Transverse colon will have a shared distributed venous supply from the superior and inferior mesenteric vein because they have the watershed area in the transverse colon. So moving on here, during a laparoscopic gastrectomy, the surgeon identifies a communicating cavity between the greater and lesser sacs in the abdomen. Which of the following forms the inferior border of this area? A, caudate lobe of the liver. B, first part of the duodenum. C, gastroduodenal artery. D, hepatic portal vein. And E, the third part of the duodenum. Okay, so again, yeah, this clearly the area between the greater and lesser sac is the epiploic foramen, and knowing the boundaries of this area is really important. And if you know those, as well as the structures that pass within the free edge of the lesser omentum, it'll be fairly easy marks in terms of when these type of questions are asked, because they do tend to come up. Now, I will show you the diagram because which will be easier to visualize. So these are the boundaries in the region of the epiploic foramen. So superiorly, you have the caudate process of the liver, and inferiorly, then you have the duodenum. And so that was the answer to this question. It's the first part of the duodenum that forms the inferior border. Posteriorly, you have the peritoneum covering the IVC. And then anteriorly, that's where you have your free edge of the lesser omentum, which contains with it the hepatic artery, the common bile duct, and the portal vein that we talked about. So, which of the following structures is not found in the transpyloric plane? A, the fundus of the gallbladder. B, origin of the superior mesenteric artery. C, neck of the pancreas. D, duodenojejunal flexure. Or E, the first part of the duodenum. Okay, so the transpyloric plane is another really key anatomical landmark that is asked about a lot. It's similar to the angle of Louis or the divisions of the thorax. The transpyloric plane comes up a lot, so it's worth just taking the time to learn the structures that pass through it. It's a line demarcated at the level of L1, and these are the structures that pass through that line. So it's a line drawn obviously halfway between the suprasternal notch and the pubic symphysis, which lies at L1. And these are the structures that pass through it. And I'm sure you've come across lots of questions that essentially relate to this anatomical landmark. Now, the answer to this question was E, first part of the duodenum, because as you can see from the diagram, the rest are included in that exhaustive list. And rather than the first part of the duodenum, it's the second part of the duodenum that crosses that landmark. The first part is actually going up more superiorly before it comes down as the second part of the duodenum. So common things, obviously the hilum of the kidneys, the fundus of the gallbladder, the second part of the duodenum, going from either, I would learn it either or, how you like it, but what helped me was just working from right to left, and that's how I did it. And I would just think through it in my head about what structures you may come across. You have the neck of the pancreas there, and so on. And so this, the transpyloric plane, it's worth learning, like the cranial foramina. It's just something to get into your minds, because it will come up. So moving on, what is the main arterial supply to the body of the pancreas? A, common hepatic artery. B, left gastric artery. C, superior mesenteric artery. D, the splenic artery. Or E, the right gastric artery. So I'll give you a few seconds for this one. Okay. So the answer to this is D, the splenic artery. So hopefully many of you would have got that. The splenic artery is the biggest contributor to the blood supply to the pancreas itself. It supplies essentially the body and the tail by pancreatic branches that come off the splenic artery as it goes along, if you can picture how it comes off the celiac axis. The head of the pancreas and the neck, I guess, they are supplied by the superior and inferior pancreaticoduodenal arteries. So the superior pancreaticoduodenal artery is a branch of the gastroduodenal artery that comes off the common hepatic artery. Sorry, I'll show you it here. And then the inferior pancreaticoduodenal comes off the superior mesenteric artery. But when it comes to the body and the tail, it's supplied by the splenic artery. Okay. And again, the celiac axis, superior and inferior mesenteric artery, knowing the branches and what structures they supply will be important. Okay. So during a Whipple's procedure, the structure directly posterior to the second part of the duodenum is injured whilst mobilizing this segment of bowel. Which one of the following is most likely to have been injured? A, fundus of the gallbladder. B, hepatic portal vein. C, the hilum of the right kidney. D, superior mesenteric artery. or E, gastric pylorus. Okay, so again, a question about where things lie in relation to others. And you'll notice again that it's asking about the second part of the duodenum, which we know lies at L1, which is part of the transpyloric plane. And so you have some structures there as possible options that are part of the transpyloric plane, such as the fundus of the gallbladder. For this, the answer would be C, the hilum of the right kidney. And so if you would, and this is why it helped me if I were to try to learn it and visualize the anatomy going from one end to the other. So either, right to left, you could try to deduce what structures are related closely or not. And so, for example, the gastric pylorus, superior mesenteric artery, then they're not really related to D2, which is over towards the right in the gallbladder. Again, if you try to visualize where the gallbladder sits in relation to D2, you would know that it's a little bit more lateral to D2. And so again, you could probably rule that out. And, the gallbladder doesn't sit behind the duodenum. It's more lateral. And so that essentially leaves you with the portal vein and the hilum of the right kidney. And again, the portal vein, we know that confluence starts behind the neck of the pancreas, more medial to the second part of the duodenum. And so the only real structure that could be posterior to this, directly posterior, so at the level of L1, would be the hilum of the right kidney. Hence, that's the answer to this question. So it would be a good idea to try to visualize this. And this probably isn't the best diagram, actually. It's good to show you what structures pass through transpyloric vein, but if you map out where these structures pass and then where in relation they are to others, it would help you in a whole host of questions that potentially come up. So on to the next one. Which of the following is not true about the jejunum? A, it is bright pink and thick-walled. B, it only has a sparse amount of lymphoid tissue. C, the jejunal mesenteric vessels form few arcades with long vasorecta. D, the jejunal mesentery is attached to the posterior abdominal wall to the left of the aorta. E, the jejunum can be macroscopically identified via Taenia coli. Okay, so sometimes it can be tricky trying to recall the features between the jejunum and the ileum and the difference between the two. But for this question, if you look at essentially E, which is the answer to this question, you would know that small bowel don't have Taenia coli, and that's actually a feature of large bowel. And so immediately you would know that that statement would not be true about the jejunum. Taenia coli is not something that you identify on small bowel, and it's actually large bowel that you see it in. And so by that, you could essentially rule out the others because you would know that that isn't true of the jejunum. And then following on from that, obviously, you would want to know, it would be good to, revise and recall the different types of features. But essentially, the jejunum is thicker walled than the ileum. This will show you better. It's larger, bigger circumference, thicker walled, and it's less fatty. And along its omentum, they have longer vasorecta, which essentially these options in C confirmed, okay? And it has fewer arterial arcades, okay? So long vasorecta with fewer arcades, whereas it's the converse in the ileum. So you have shorter vasorecta, but many loops in the arcades, as well as it being smaller circumference and thinner walled, okay? But yeah, in these type of questions, just look out when it's a question about ileum and jejunum and whether it's a true or false statement, look out for features between small bowel and large bowel as well. Okay, so which of the following statements about the inferior vena cava is correct? So A, oh, sorry. Apologies, you may have seen that, but we'll go through it anyway. A, it lies to the left of the abdominal aorta. B, it enters the diaphragm with the thoracic duct. C, it is a retroperitoneal structure. D, it has 3 valves in the abdominal cavity before entering the diaphragm. And E, it is contained in a groove on the posterior surface of the pancreas. Okay, so the answer is C, and it's that the IVC is a retroperitoneal structure. And if you remember, like loads of people have different mnemonics for it, but for example, Sapaka, and knowing your retroperitoneal versus intraperitoneal structures, you would know that that would be correct of the IVC. Both the aorta and the IVC are retroperitoneal structures. Just going through the rest, the IVC lies to the right of the abdominal aorta. Obviously, within the diaphragm itself, the inferior vena cava, it doesn't pass through with the thoracic duct. Okay, so the IVC passes through at the level of T8 in the diaphragm and goes through with the phrenic nerve rather than the thoracic duct. IVC, it doesn't contain any valves within the abdomen. So we know that that can't be true. And then again on E, it's not contained and it doesn't run, it's too posterior to be running through a groove on the pancreas. Okay, so, but here, the key really is if you know your intraperitoneal versus retroperitoneal structures, this would be quite a relatively straightforward question to get. And here, attached are some of the retroperitoneal and intraperitoneal structures. Okay, so we'll squeeze in a couple more questions. At what anatomical position do the ureters insert onto the bladder? So A, and sorry about that, it would be anteromedial aspect, B, the posterior medial aspect, C, anterolateral aspect, D, posterolateral aspect, and E, superior aspect of the bladder. So what anatomical position do the ureters insert into the bladder? I'll give you a few seconds for this one. Okay, so this question, for some reason, seems to come up a lot. It came up in my exam, it came up in several of my colleague exam who did it at different varying points, not in the same sitting. And the answer is posterolateral. So the ureters, as they travel down, they travel more laterally in the pelvic walls once they do reach the pelvic cavity. And then roughly around the levels of the ischial spines, they then turn and travel anteromedially. So that's the direction the ureters travel. But obviously onto the bladder itself, it would be at their posterior lateral aspect. So the ureters travel from a lateral position at the back of the wall in an oblique manner towards the bladder. And so with the bladder being central, and it's probably better to show you the actual picture, sorry, the ureters would come and insert onto the posterior lateral aspects of the bladder itself. So not superiorly, because it's traveling obliquely from the posterior lateral walls of the pelvic cavity. You know, it doesn't loop around anterolaterally, and it's not medially. Okay, so it inserts laterally. And yeah, this is a question that came up in my exam, like I said, and quite a few other people. So it's something, just keep a note on it, because it's quite a simple question, but it's something that you probably would skirt over when you're studying. Okay, so a 65-year-old man presents to his GP with a groin lump. Examination reveals a reducible inguinal hernia. Which of the following is not a boundary of the inguinal canal? So, which is not a boundary of the inguinal canal? A, transversalis fascia, B, the inguinal ligament, C, lacuna ligament, D, the conjoint tendon, and E, pectineal ligament. Okay. So the answer to this would be E, the pectineal ligament. So the boundaries of the inguinal canal, femoral canal, or femoral triangle, femoral ring, sorry, as well as the femoral triangle, they're, and knowing the structures that pass through them is, definitely going to come up in the exam. And so it'll be good to just keep going back to them and reminding yourself, because sometimes, it can be tricky because some of the ligaments, lacuna, pectineal, conjoint tendon, they can, I always found it hard when I was studying. So just going over the diagrams, drawing out the diagrams with the tendons and ligaments. And I had to do that quite a lot for it to stick. But for this question, it is E, pectineal ligament, because that forms part of the femoral boundaries of the femoral ring rather than the inguinal canal. So the boundaries of the inguinal canal, you have anteriorly, you've got the aponeurosis with the external oblique muscle, which is reinforced by internal oblique. Posteriorly, you've got transversalis fascia, and that's also reinforced by the conjoint tendon, which is D. The roof is also made up of the transversalis fascia. And then obviously the floor is the inguinal ligament itself, which is B. And that's, again, reinforced by the lacunar ligament medially. So the odd one out here is the pectineal ligament. And some people find, I sometimes found it useful, but this is just something MALT. The boundaries contain two muscles, two aponeuroses, has two ligaments, which is lacunar and inguinal ligament, and then the conjoint tendon and transversalis fascia. Some people found it helpful, some people didn't, but that's something you could maybe see and see if it works for you. So I think we'll do one last question with it coming up to an hour now, and then we can open up the floor for kind of just general questions, if you have any other questions about the tips for the exam, what materials, etc., we can do that. So a 60-year-old gentleman is having an inguinal hernia repair. The consultant asks the trainee to identify whether the hernia is a direct or indirect hernia. What anatomical landmark is most helpful to help answer this question? A, mid-inguinal point. B, the pubic tubercle. C, midpoint of the inguinal ligament. D, the inferior epigastric artery. Or E, the lateral border of rectus abdominis. Okay. So the answer to this question would be D, the inferior epigastric artery. And the main reason for that is because it also forms the boundary of the Hasselbalch's triangle, which I'm sure you are aware is a weak point in terms of the location of a direct inguinal hernia in which that can happen. So just working through these, E, the lateral border of the rectus abdominis, although it is also part of the Hasselbalch triangle border, a lump or hernia may happen anywhere lateral to it anyway, so it's not really helpful in that regard. C, the midpoint of the inguinal ligament is the location of the deep inguinal ring. And so, some people may think that, that might be a good location to find. So if you could potentially reduce a hernia, then occlude that area and ask for someone to cough. Do you feel pressure on that area or not? But, it's less sensitive than the actual landmark of the inferior epigastric artery, because if you don't know where that is, and you have a lump that comes medial or lateral to it after you've reduced it, if it comes medial to it, you would know that that is protruding through the Hasselbalch's triangle and that it would be a direct inguinal hernia, whereas anything lateral to it is most likely to be a indirect inguinal hernia. The mid-inguinal point wouldn't really give you anything. That's just the location of the femoral artery. And then B, the pubic tubercle, again, is just too medial to give you any clues about whether this is a direct or indirect hernia. And so the key here is whether knowing the boundaries of the Hasselbalch triangle, and then knowing that it's, it's the lateral border of, which is the inferior epigastric artery, rather than its medial border, rectus abdominis, that would be helpful in assessing for that. So given the time, that's an hour. So we've covered a fair few questions there, and I hope you found it useful. It's so how this is set up, I can't see the participants who are part of this session burned, and so sorry about the lack of interaction in there. But I'm happy to stick around for about 20 to 30 minutes, answering any questions that you guys have, or just general things about the exam itself. Otherwise, the next session will be on Friday, this Friday on the 7th, and that'll be part 2 of anatomy. So we'll cover the rest of the key topics, including kind of limbs, the rest of the abdomen, and various other kind of questions that we felt came up fairly frequently for candidates who've sat it at varying points in the past few years. And yeah, as a final thing, if this is a QR code for our feedback link, I'll leave this slide up for a little while. If you guys could scan that and provide some feedback, that would be really, really helpful, so that we can, tweak or tailor the remaining sessions in this MRCS series to benefit you guys. On top of that, we have other sessions that are coming up. Okay, so at the moment, if you follow the Twitter page, you'll see the schedule, but it will roughly be 2 sessions per week. The second anatomy session, as I said, will be this Friday eve. Next week, there'll be 2 applied physiology sessions, and then after that, we'll be going through kind of specialty-based, covering high-yield questions that come up in those. So, head and neck, cardiothoracics, trauma, all of those things.
There are a few questions in the chat.
Oh, sorry.
That's okay. I'll read them out to you, so then everyone can so would you mind please telling us which resources you used for the MRCS?
Yeah, so I mainly used MRCS question bank, which I'm sure, I think most people use that, as well as PASS test. I felt in terms of difficulty level, I thought EMRCS was more reflective. However, PASS test I felt was better, particularly early on in my revision, because you can have it on your phone, you can download the app, and it's a lot quicker to just drill questions on the move, even at work, in between sessions. Whereas EMRCS is a bit more wordy and slightly more difficult, but it was a bit more reflective of the actual exam. Other than that, in terms of just base kind of theoretical revision, which I tried to do fairly early on in studying, I used Raftery textbook, which a lot of people use as well. I used that mainly for physiology. The Raftery passed the MRCS textbook, and that the anatomy part of that, although it's really relevant to the exam, the lack of diagrams, it was a lot of prose text, which I didn't find too useful. So I used a lot more just Google, teach me anatomy resources. And as I was going through kind of MCQ questions on anatomy, I would just read around that. So mostly teach me anatomy, Ken Hub for anatomy. For physiology, I did use Raftery textbook, which I found very helpful. And then PASS test and EMRCS. And I probably went through both question bank twice before the exam.
And someone's also said, if you can remember as well, what score were you achieving on EMRCS before you passed the exam?
Ooh, so really variable. When I first started it, especially on my first run through, honestly, I wasn't scoring highly at all. I was probably ranging anywhere between mid 50s to low 70s, especially for, anatomy questions. I think the specialty-based questions I found a lot more palatable, and I was doing better on those. So hitting around the 70% mark for specialty-based questions. I did better on the past test questions because, again, I think the standard on the past test questions are slightly lower than the MRCS, just purely based on difficulty. But then second time round, because the first time round I was doing it, it was taking more time, but as I was going through it, reading around each question in a bit of detail. And then the second time round was just more drilling questions, trying to get, buzzwords, pattern recognition. And on that, I was probably doing better in terms of getting roughly mid 70s and above. Yeah, but first time going through it, I wouldn't worry about hitting varying marks.
Perfect. There's one last question, which is they've done it. Innocent sorted it. I think there's no more questions. If anyone has any last minute questions, chuck them in the chat or in the Q&A. And if not, we will see you guys on Friday.